Hi, this is Courtney DiNardo from the Department of Leukemia at the University of Texas MD Anderson. Today I will be talking about strategies for patients unfit for traditional induction therapies for AML. So first we should define what we mean by patients unfit for intensive chemotherapy. This certainly includes patients 75 years of age and older, also perhaps patients with significant comorbidities, cardiovascular, pulmonary. We may also want to start considering patients who are inappropriate for standard intensive chemotherapy, such as those patients with adverse cytogenetics or p53 mutations or antecedent hematologic disorders, patients who are insensitive to cytarabine-based therapy and may benefit from other treatment options. So this rather sobering picture demonstrates that despite significant improvements in the overall survival of younger patients with AML as shown on the left, minimal, if any, improvements can be seen in the older patient population, with the curve on the right representing those patients 60 years of age and older, over several decades showing really minimal incremental improvements. In terms of standard therapies for our older unfit patients, the first common and long-standing treatment option available is low-dose cytarabine, or LDAC. Here, it is shown to be significantly better than palliative hydroxyurea and leads to an incremental overall survival improvement, here to only about 4 months on average. Expectations with the hypomethylating agents compared to physician choice, often including low-dose Ara-C or supportive care. On the left is azacitidine, on the right is decitabine, show modest improvements in overall survival with hypomethylating agent therapy, with median overall survival of approximately 8 to 10 months with a hypomethylating agent. So while low-dose Ara-C and then the hypomethylating agents have improved the care of our older patients with AML, long-term responses really are quite unusual, with median overall survival well under a year with these current therapies. Several studies are now demonstrating there are promising improvements using either low-dose Ara-C or hypomethylating agents as backbones to rational combinations. And this first study describes a randomized phase 2 clinical trial of the hedgehog pathway inhibitor glasdegib, given orally once daily in combination with low-dose Ara-C versus low-dose Ara-C alone. The primary endpoint is overall survival. And here we can see that there is indeed a significant survival benefit in those patients with AML and high-risk MDS who were treated with a combination of low-dose Ara-C and glasdegib, with a median overall survival of about 9 months. And furthermore, we can see the survival benefit was sustained among different genomic subgroups classified by cytogenetics. And this suggests that the addition of glasdegib to low-dose Ara-C may represent a novel treatment strategy for patients with AML or even high-risk MDS that are not fit for intensive chemotherapy. Another promising study shown here is the phase 1/2 trial of the oral BCL2 inhibitor venetoclax, given in combination with low-dose Ara-C for elderly unfit AML patients. The dosing schema of the venetoclax is shown here, with a week-long ramp-up to a goal dose of 600 milligrams orally daily of venetoclax. The response rates with this combination are notable. On the left, you can see an overall complete remission rate of 25% and a CR/CRI rate of 62% in the entire treatment population of about 61 patients. Furthermore, the median overall survival for this study population is about 12 months, which is particularly notable in the curve on the right, as is seen in the patients with intermediate risk cytogenetics, with a median overall survival that at the time of the last presentation had not been met, suggesting a significant improvement with this treatment combination, which is now being evaluated in a randomized phase 3 trial. Now, moving on to hypomethylating agent-based therapies, we can first discuss a new hypomethylating agent on the block. So this is SGI-110, or guadicitabine. This is a second-generation hypomethylating agent which leads to increased exposure, which is hoped to then translate into improved patient efficacy. Updated data from a phase 2 study demonstrates improved CR and CRI rates with SGI compared to first-generation hypomethylating agents, and a randomized phase 3 study of guadicitabine in AML patients unfit to receive intensive chemotherapy called the Astral-1 study is now enrolling. Venetoclax is also being evaluated in combination with the hypomethylating agents, decitabine or azacitidine, in older patients with AML. And here you can see updated data from the first 145 patients treated on the phase 1/2 study of this treatment combination. The response rates by treatment are shown here, and on the very leftmost column, you can see that overall in all patients treated at all venetoclax dose levels and both azacitidine and decitabine as a hypomethylating agent, the overall response rate is up above 80%, a CR/CRI rate of 67%, and a CR rate of 37%. Furthermore, the response rates for the various patient subgroups, including cited genetic risks, newly diagnosed versus secondary AML, de novo versus secondary AML, I should say, and age, stratified by 75, older or younger, are shown here and show response rates across these important stratification factors. And finally, overall survival is shown here, with all patients shown in the green curve with a median overall survival of 17.5 months, and in patients receiving 400 milligrams of venetoclax, a median overall survival that has not yet been achieved. And notably, a phase 3 study of azacitidine with venetoclax at 400 milligrams is now underway. And so in conclusion, well-tolerated combinations with hypomethylating agents or low-dose cytarabine as backbone strategies are demonstrating improved efficacy, both improved response rates and improved overall survival. Several phase 3 studies are now ongoing to confirm the favorable efficacy that have been identified in these earlier phase 1 and 2 trials, and we are hopeful to have new agents and new combination therapies to offer to our patients soon. I want to thank you for your attention.